All right. You see that, I assume.
Yep.
Okay. And then you see my PowerPoint?
Yes.
Okay, good.
Is the last case that one that we saw? Okay.
Yeah, it is.
I was like, this looks familiar.
Good eye, good eye, good eye. Yeah, it's a good discussion because, I'd never seen one. And that happened. You're not going to see everything in residency that you're ever going to diagnose. So it's um, I feel like a good practice run through how to deal with that.
Yeah.
You have a recut of that, don't you?
Yeah, because I pulled it out and I was looking at it and I was like, this
Oh,
looks
yeah,
very
yeah.
similar.
Yeah. And then didn't you give a recut to one of your attendings?
Yeah, I gave a few around. I actually got a bit of pushback on the way we signed it out, so God, I keep going back and forth.
On the way you and I signed it out?
Yeah, some people liked a different diagnosis, and I'm
Like what?
canalicular adenoma.
No fucking bullshit.
Well, so to me, the stroma looks a lot like it.
That's bullshit.
Okay,
I should pull my canalicular adenomas. That's bullshit. Okay, you should not be listening to whoever told you that.
all right.
I need to I need to pull my oh, I should do that really quickly. Well, let me that's ridiculous. Um you almost never see that outside the upper lip.
Well, so okay, I think the blue book says that buccal mucosa is another place you can see them.
Yeah, you can see it. It's like I can get a basal cell carcinoma in my asshole. That doesn't mean I'm going to
Yeah,
see
right.
it. Um, let's see. I'm gonna. 126, 152. All right, I'm glad you said that. I wouldn't have even considered that because I've seen so many of them, and it didn't look like that at all. So,
Yeah, you
anyway,
don't think the stroma looks kind of similar?
no,
Okay.
I'll go over why. Okay, so let's get started. Oh, now I really need to make sure I get to the last case since you guys are wrong again. Okay, so this first one is a 63-year-old woman with a positive fecal occult blood test, recently diagnosed invasive lobular carcinoma of the breast, and that she has a large malignant appearing mass that was noted in the cecum and was biopsied. It was more like ascending colon. Okay, so this is the case. Most of this is not normal, but like inflamed looking. You have ulcer debris. Fibrinopurulent exudate. This almost looks kind of hyperplastic. Maybe in the cecum ascending colon, you think it's a cess-ulcerated lesion, but then you come to this, and this does not look like a hyperplastic polyp. It doesn't look like an adenocarcinoma. These are markedly atypical nuclei in the stroma. That's huge. I mean, these are huge. They almost look like what you see in a well-differentiated liposarcoma, like lipoblast. Look at that. This is just like, and there looks like there may be necrosis here. I mean, look at that nucleus. That's huge. That too, this. So it's something very atypical infiltrating between the glands. Now, some of these are crypts that are glands, crypts. crypts that are cut kind of perpendicularly, and they almost look like multinucleate cells, but you can see they're very different than the actual neoplastic looking cells that are markedly atypical. Kind of what you'd see like in an undifferentiated pleomorphic sarcoma, maybe anaplastic thyroid carcinoma. She has this history of lobular carcinoma. Does lobular carcinoma go to the colon and GI tract? Yeah, it's one of the more common mets there. But even a pleomorphic lobular carcinoma shouldn't look anything like this. This is just like a giant cell carcinoma, but it's not growing like a carcinoma. It's growing in between the glands, is not displacing them. It's kind of, sarcomas do this. You usually think of sarcomas as having a pushing border. They can infiltrate in the colon even when they're metastatic. I've seen that several times. So, I wasn't really sure what to do with this. I mean, it didn't look like, I've seen a lot of leiomyosarcomas go to the colon. Could it be a GIST? We're talking about the GI tract. What about primary spindle cell malignancy? A GIST? Yeah, you can see a GIST kind of infiltrating, but usually they're not, you never say never, but usually they're not markedly atypical like this. So it's, I didn't really have a whole lot to do. I did a keratin stain. This is a pan-keratin, thinking, well, if this is lobular carcinoma, even pleomorphic lobular carcinoma, those tumor cells, those markedly atypical cells should stain positively. There's some positive staining, but a lot of this is just uptake from hemosiderin that was in the stroma. These actual markedly atypical cells are negative. Here is S100. Ancient change in a schwannoma can look like this. Something benign that could potentially have marked atypia. So this is S100. If this was really a schwannoma, which you do get in a GI tract, they should be positive.
Paul?
Yeah.
Would you see a schwannoma kind of infiltrating around glands like this, though?
Yeah.
You could. Okay.
You can. So, and that was negative. Here's SMA. So some of these look like they're positive. Some aren't, but I think some of them are. So what do you do with that? I don't know. That's really not specific. It doesn't mean it's a leiomyosarcoma. Desmond was negative. I think I had done myogenin. We don't have MyoD1. That was negative. I did kind of a lot, and eventually I kind of ran out of tissue, and everything was sort of non-specific or negative. This is Key 67. Some people have reported using Key 67 as a way to differentiate benign versus malignant stromal tumors depending on the staining pattern. I haven't had that much. I've been fooled by it, actually, where I'm going to see a case where I've been fooled. Well, I wasn't fooled, but it didn't stain the way it I would have expected. So I have stopped kind of using Key 67. This was not something I was going to hang my hat on whatsoever, but a lot of these cells were negative. They're kind of, if this was like a high-grade malignancy, you would expect that Key 67 would be very high. It doesn't always correlate like that in tumors, but it was just kind of, I was reaching. I didn't really know what to do. There's just one tissue fragment. There weren't a lot of actual markedly atypical cells. So I kind of, when a case like this, you kind of have to go to the clinical history, try and look around more, do some research. So I looked at the colonoscopy report, talked to the surgeon who told me that, as I put in the clinical history, said this was large malignant appearing. So if you just see marked atypical cells without any context, you see that in trophoblasts can be really atypical. Symplastic leiomyoma, bizarre atypia, that you can see that in the setting of what otherwise looks like something's benign, and the fact that the background looks like it's benign would make you back off and not call something malignant. But when you're being told this looks malignant and then the cells look malignant, that is, how you go down that path. And then CT scan report. I don't know where they got this, but they had said, 4.6 cm mass in the ascending colon, consistent with the history of adenocarcinoma. Of course, it's radiologists. You can't listen to anything they say. But again, they are also saying this looks malignant. The surgeon saying it looks malignant. But I still didn't call it malignant. I said ulcerated colonic mucosa involved by markedly atypical epithelioid and spindle cells. I said it was unusual. And I said that, the big spindled and epithelioid lesion in the GI tract would be a GIST, and it was CD117 DOG1 negative. I didn't show you that. So I said that would argue against a GIST. Plus, like I said, the atypia, I've never seen a GIST like that. It looks that markedly atypical. It doesn't mean it can't happen. I'm sure it's been described and been seen. I said it wasn't necessarily specific immunophenotype, but you could see it in a leiomyosarcoma, benign and malignant peripheral nerve sheath tumors, because I mentioned that this could be something benign, as well as metastatic malignant melanoma. I did S100 SOX10, they were negative. That does not disprove melanoma, especially in the GI tract. As a MET with spindled features, they can be S100 and SOX10 very focal. And if I just have one piece of colonic mucosa that's involved, it could absolutely be melanoma. So I talked to them. I said, you really need to size this, take it out. It sounds like it's malignant. I can't call it malignant. And the reason why I would not call it malignant, because they really pushed me to call it malignant. I don't know why, if it would really change anything. But I've mentioned this before. One of my neuropathology attendings at Mass General, Tessa Headley White, and she had several very good pearls. And one of them is if you don't know what something is, you don't know whether it's benign or malignant. So don't use those words in the final diagnosis. If something looks benign, but you're not sure, you can call it bland. If something looks malignant, but you're not sure, call it markedly atypical. You can now in a comment, you can kind of postulate and give a differential and talk about the different things. But as far as your main diagnosis line, don't use those words generally if you don't know what something is. So I try and kind of follow her advice. She was fun to work with and very smart. So they did a right hemicolectomy, and this is what it looked like. I took gross. So I was waiting for this. It took them like 6 weeks to take it out. I was waiting for this case because I was dying to know what this was. And when you see this, so you can see it's like, this large pedunculated mass that's very lobulated. You can see it looks ulcerated in the background of kind of normal looking colonic mucosa. When you see this, for me, I was like, this is benign. Because if this was anything malignant, it should have been a sarcoma, was my thought process. This is not how a sarcoma would spread to the colon. A sarcoma would be kind of extramural, and that's what they were telling me. They were telling me this seemed kind of extramural. I don't know how the surgeon thought this was extramural. It's like flapping in the wind on this stalk. There's nothing that looks extramural about it. In fact, I even amputated a stalk to take a better picture of it. And then I bivalved it, and you can see it's got this kind of cystic appearance. This stalk looks, totally normal. So looking at this, thinking about the case, I'm like, I think this is going to be some weird kind of benign thing. I don't know what it's going to be. So I have the slides from that.
God,
So
is this all just going to be reactive atypia?
Well, you're going to have to wait and see. So this is it. So it's got these really dilated glands. A lot of them have inspissated mucin and neutrophils. This is kind of the classic appearance of a juvenile polyp. Inflammatory polyps can look like this. They generally don't have as dilated the glands. Now, some juvenile polyps in adults, which you get in adults, juvenile does not mean that it's a child always. It just describes the hamartomatous kind of nature of it, because you get them in adults. But when you have this mucin, neutrophils, cystically dilated glands like this, that's often something you see in a juvenile polyp. They can be solitary or multiple. Again, most inflammatory polyps, which are also non-neoplastic, usually arise in the background of an inflammatory bowel disease. Now, most of what's here, is not atypical in the stroma at all. But then if you go to some areas where there's ulcer, you can see the atypical cells at low power right under the ulcer. And it's that same marked atypia, and it's marked atypia. And there were some mites in some of these cells. I mean, these really look malignant. But what is weird about that is that it kind of merges with areas that don't look malignant. As you get away from this ulcer, it's no longer malignant looking. And I submitted a bunch of sections of this thing. Here's another one. So again, most of this just kind of looks like inflammatory, non-neoplastic. Some of these cysts look like they've been denuded, the cystic glands, I should say. And then you've got these areas that look real. I mean, this looks like if you had a core biopsy through this and they said soft tissue mass, you'd call that sarcoma every day. This looks like sarcoma. But again, as you move away from that surface ulcer, this sarcoma mysteriously matures into what looks like reactive stroma with hemosiderin and inflammation. So I did a big literature search, and it's very, very rarely described in the colon, but you can get benign non-neoplastic polyps that have pseudosarcomatous change. Is that a diagnosis that I'm going to make alone? Abso-fucking-lutely not. Because if this ended up being some weird sarcoma arising in a polyp, which I'm sure is also described, and I call it benign, and then the person presents a couple of years later with lung lesions, and it looks like it's from this, that's a bad mistake. So when these things are rare and you're alone, you show your colleagues, but then be careful who you show, because you may show someone who thinks it's a sarcoma, and then you don't just believe them just because they said that. So I actually sent this to one of my friends who is at Mass General. She's a really good GI pathologist, Mari Knudsen. And I told her that I thought it was a juvenile polyp with bizarre atypia. I said I found several reports in the literature with atypical stromal cells of polypoid lesions of the GI tract, but they're mostly inflammatory polyps. There's kind of a discussion about inflammatory versus juvenile polyps in adults. But again, I made a comment and I showed you the gross. The remainder of the bowel is unremarkable, and this would be a large inflammatory polyp. They usually don't get over 3 centimeters. This was over 4 centimeters. So I sent it to her with the gross photos, and then she agreed that it was basically pseudosarcomatous change, but she called it inflammatory polyp and didn't even tell me why she didn't think it was a juvenile polyp, which I did not like, despite the fact that I really like her personally. And she's a very good pathologist. I didn't like that she didn't address my question. When you're a consultant and someone's sending you something with a specific question telling you about, the type of polyp and the fact that inflammatory polyps are almost always in the background of inflammatory bowel disease, that there was no inflammatory bowel disease or any history of colitis or ischemia or anything, and this would be a weird place for ischemia anyway, that was kind of disappointing. But anyway, the bottom line is that she agreed that there was no evidence of sarcoma. So I just thought that was a really interesting, scary case. I could have really gone down the tubes on the biopsy. Now this is another case where this was a case I had, I think in Mountain View in Las Vegas, where you have this very cellular spindle cell lesion involving the small intestine. Remember, small intestine is one of the few places in the GI tract where metastases are more common than primary tumors. And you have some of these very similar looking, markedly atypical cells. But here there's actually more mitotic activity. It's more diffusely hypercellular. Here you have the whole lesion. It actually is infiltrating into the glands. Some of these stromal tumors will do that. They'll go into the lamina propria and think, oh, well, usually sarcomas are well defined and pushing. In the GI tract, that's not necessarily true. Even when they metastasize, usually think of Mets being very well defined and rounded the way they're described in the lung. This is infiltrating beyond the muscularis mucosae into the lamina propria. This was an undifferentiated pleomorphic sarcoma, basically a diagnosis of exclusion. But this was a high-grade sarcoma that had metastasized. It was primary in the patient's leg. I think there was their thigh, and it metastasized to the GI tract. So you do get, I have a really, unfortunately, very faded case of a metastatic leiomyosarcoma, not a GYN leiomyosarcoma, like a retroperitoneal leiomyosarcoma, on a biopsy that looks identical to the biopsy I had here. But the person had a history, but it was highly malignant cells surrounding glands. It's so faded that it would not project on here. Now, when you normally see atypical spindle cells, a spindle cell tumor in the GI tract, the thing that I've showed you multiple examples of is what this is, which is a spindle cell melanoma. So this was actually a primary spindle cell melanoma, primary in the anus. Now, when you have overlying epithelium, if you think something might be a primary melanoma, look for a junctional component because you may see it. Don't spend so much time looking for pigment, although that kind of looks like pigment here. Because this is pigmented actually. Most primary mucosal melanomas, anal, oral, are amelanotic as opposed to the opposite in the skin where most of them are melanotic. But you can see this just looks like some sort of spindle cell tumor. You would not think melanoma, and you usually don't. This is something you have to force yourself to think about or know the epidemiology to make sure that you think about melanoma in a context like this. But this was a spindle cell melanoma. Those are not UV associated. They're most likely older patients, more often older women, especially anal melanomas, older white women. It's kind of the demographic that gets anal melanoma. And then this, now we're in the duodenum. And this is kind of looks a little cellular. These can be very subtle. We don't see this very often anymore. So it looks hemorrhagic, kind of. Looks cellular. It's hard to like make out. It looks kind of spindled. Lots of extravasated red blood cells. Let's see. Let me get this in the field. Have some hyaline globules. Look at that. This is an HIV positive patient. What's this? This is Kaposi sarcoma. So HIV patient, HHV8 positive, usually gay men. These patients usually have cutaneous lesions. Most HIV positive patients that are immunosuppressed enough that have Kaposi's cutaneously will also have it in the GI tract. Interestingly, when they have it in the liver, it's really usually asymptomatic and doesn't do anything. On the GI tract, it can, for obvious reasons, cause bleeding. These regress when you take them, when you kind of remove their immunosuppression, basically by treating them for HIV. You often will see a lot of extravasated red blood cells. You'll see these hyaline globules. There's a ton of hyaline globules. They're both extracellular and intracellular. This one doesn't have as much hemosiderin. Usually you'll see some hemosiderin. I've had cases where I've almost missed it because this just looks like maybe a little cellular, like if you just got this, and you'd say, oh, well, there's a little stromal hemorrhage from the biopsy procedure. No, this is all Kaposi sarcoma here, expanding, lifting the small intestinal crypts off the mucosal, the muscularis mucosa. This is Kaposi's. So this can be very subtle. Like I said, we don't see this very much anymore with HIV therapy being as good as it is now. And then this is another spindle cell lesion. Let's look at this. This is a really good case. So this is a colon polyp. It looks expanded. It looks too much to be like prolapse or anything. Prolapse, usually you have hyperplastic changes. You usually have rounded crypts. So this kind of looks bland, spindled. Kind of hard to put a name on it. Usually these are like, they call them benign fibroblastic polyps. Perineurioma can be kind of look like this. But then if you go to the other piece, there are these glands in it that don't have goblet cells. They don't look like the colonic crypts. Anybody know what this is?
Endometriosis.
Yeah, this is endometriosis. This is hard to think about, but you really should think about, because about a third of cases of endometriosis in the peritoneum will involve the GI tract, small and large intestine. Now, usually they're extramural and they involve the serosa, maybe the muscular propria, but sometimes they can be transmural and present as polyps. I am usually wrong when I think it's endometriosis, because a lot of times colonic crypts, when they get inflamed and deep, can lose their mucin, and they look like they don't have goblet cells, but they've just become kind of mucin poor because they're regenerative and reactive. It's easy to do with immunostains. Paxate would be positive endometriosis, CDX2, SAPI2 would be positive in colonic epithelium, but this has all the features of endometriosis. You get these, pseudostratified glandular epithelial cells, endometrial stroma with stromal hemorrhage, kind of like Kaposi's, and then hemosiderin. So that's endometriosis. And just like endometriosis anywhere else, you can have the same malignancies, endometrioid adenocarcinoma, clear cell carcinoma, arising in endometriosis. All right, speaking of endometrium, let's look at the second case. So the second case is a 58-year-old woman with a 2-month history of intermittent cramping and vaginal bleeding. An ultrasound showed an endometrial lining of 9 millimeters, and endometrial biopsy was performed. So here's the endometrial biopsy. So I usually start at low power with these, and immediately you see a lot of little strips of epithelium. An older woman, she's almost certainly postmenopausal. This is probably all inactive to atrophic endometrium. So you wouldn't normally expect to get a big fragment of endometrium like that in an older woman. So when you do, your first thought should be that it's a polyp, that they got a piece of a polyp. Because a lot of times, if you're not thinking that something's a polyp, you're just going to think, oh, it's kind of proliferative, disorder proliferative. But then, look for the kind of fibrous stroma, the large, thick-walled vessels. Now, remember, Basalis has prominent vessels. This is too thick, this is too fibrotic, and it's too big. So this is a benign endometrial polyp. It's a little hypercellular in the fact that the glands are a little more prominent than some of these, but still it's not, you allow for some increased glandular density in endometrial polyps without freaking out. But like I've told you multiple times, when you have an endometrial polyp in an older woman, especially in an older woman, you need to go around and look for serous carcinoma, because that's where you see serous carcinomas. And if you're not specifically looking for it, if you're just going to kind of rely on your eye to catch it, I'm telling you, you're going to miss it. I've seen it missed by so many people. So I looked around and I didn't see any. So I'm like, okay, well, this one doesn't have them. Plus 58 was a little on the young side for a serous carcinoma. But then, I go around and I look at the rest of the epithelium and I'm like, wait a second. That looks really atypical. Compared to this is benign looking with cilia. That is very atypical looking. Look at that nucleolus. So is that some metaplasia? Would she have a reason for metaplasia? Does she have breakdown? Well, actually, she does have breakdown in the background here. Like there's some breakdown. So is this some kind of weird metaplasia, almost like a Ariostella looking? Why would she have Ariostella? Is she on a medication? There's some blood, some fibrin, so she's bleeding associated with the breakdown. So you kind of have to be careful in that setting to not overcall things. And if that was all I saw, I would hope I would not have convinced myself out of it, because sometimes I feel like I do. I try and make things kind of all fit, background, a breakdown, and otherwise benign looking. Maybe this is just some reactive change. But then I saw more of this. Like, no, I'm sorry. There's nothing else this can be, in my opinion, other than a serous carcinoma. This is like really, really malignant looking. But thankfully, we have stains that we can do. So there's no way I was saying that out without doing stains. So here's P53. These are usually mutant staining. So notice the polyp did not have anything on it. This is P53. But that little fragment right next to it has diffuse strong staining. So this is P53 mutant. They're those same markedly atypical cells. So that fits with a serous carcinoma. I usually do 3 stains. I do P53, P16, and Ki67. Here's P16. Usually it's the same quality as P53, which it's not quite. In this case, there's some areas that look kind of block-like, but a lot of endometrium, tubal metaplasia can kind of have strong staining. There were those other areas. A lot of those other areas were also strongly positive, so that's a little bit better. You can see these background nuclei are very atypical, so that's a little better. The thing that scares me, which is what I kind of alluded to earlier with the Ki67, is this Ki67 is not impressive. Usually in the cases I've seen, Ki67 is like off the charts. And look at how many of these big malignant looking cells are negative. Most of them. I think that's unusual. So that kind of bothered me. And some of these other areas, there's a little more. Like that looks pretty high. But then look how many that are negative. I think that's a lot that are negative for something that looks so malignant and something that you think is a malignancy, a high-grade malignancy. We don't even grade serous carcinomas in the endometrium. They are by definition high-grade. It's not like the ovary where you grade them. It's low-grade and high-grade. So because it made me a little nervous, I still signed it out as serous carcinoma, but I wasn't just like serous carcinoma. I said superficial fragments, markedly atypical endometrial epithelium with P53 mutant expression, most consistent with serous carcinoma in background and endometrial polyp and breakdown. And so I described how I came to that diagnosis that was most consistent with superficial serous carcinoma. I was alone. My colleague was on vacation, so I had no one to show it to. But that's how I signed it out. This was, about a month ago. And then when I was pulling the case for this conference, it wasn't in the file. And then I asked the secretary. I said, "Hey, where did that case go?" And they said, "Oh, well, some other pathologist from some other large institution wanted to see it because they had the hysterectomy." I was like, "Oh, fuck!" Like, are they going to disagree with me? Because then, if this woman didn't want a hysterectomy, and they end up saying this is some really reactive thing, because again, that Ki67 kind of screwed with me, the fact that it was so unimpressive. And so I ended up, long story short, touching base with the pathologists, and they showed it at a GYN tumor conference because the hysterectomy they submitted in the entire endometrium, there was nothing left. But they looked at my biopsy and they all thought it was really subtle and small, but they all agreed that it was serous carcinoma. So I was very relieved that they didn't overturn that diet, because that would have been could have been a bad thing, depending on how the patient felt about having her uterus out. And doing staging, they did staging, which is what they should do for a serous carcinoma of the endometrium. So, and like I've said, this is something that happens a lot. You see and that's actually not uncommon with these serous carcinomas that are superficial in the endometrium or in a polyp, is when you take it out, about a quarter of the time, you're not going to see anything else. This was another big endometrial polyp that had, looks more like endometrioid atypical hyperplasia, but then some areas look much more atypical, especially when you see it in comparison to these kind of more benign glands. See how it's lighter looking because it's the nuclei have more of an open chromatin pattern. Some of these areas look much more serous slit-like spaces, especially adjacent to this benign background endometrial epithelium. So this is a lot easier. When you have a case like mine, it's much more difficult. And then this was a case that a colleague showed to me in the state that shall not be named, actually asking if I thought it was a Müllerian adenosarcoma. And it kind of looks like one at low power. You know, you look for large, rigid-looking glands, kind of a cuffing of the stroma. The stroma should be, when it's cuffed, it should be very cellular, mitotically active. This is definitely more cellular, but it wasn't that mitotically active. This is a lot of times with these endometrial Müllerian sarcoma, adenosarcomas, the way it's diagnosed is that it's called, the woman has large endometrial polyps that kind of come back and come back and come back. And eventually someone says, oh, this is an adenosarcoma. So I was kind of thinking this might have been a very subtle adenosarcoma. You know, there's really no good way to tell it other than just morphologically, but a lot of it did not look like it. So I was kind of favoring that it's probably not. Maybe you could say endometrial polyp with increased cellularity, the stroma. But then as I was looking around, I was like, wait a second, what's that? And this is high-grade serous carcinoma. See how different that looks? I'll go to 40x. Look at these cells compared to that. Very different looking. So then you go around and then there's a lot of it. This is all serous carcinoma. That's all serous carcinoma. Even this I think is serous carcinoma, even though it looks flat and single layer. Again, this is all serous carcinoma. This is even flattened looking serous. This is serous. So this morphology, and this is very focal in this endometrial polyp. You have to really be careful with these. I'm telling you, when you have an endometrial polyp, you really need to take a extra time and look for these. Look for serous carcinoma. You know, when I was a post-sophomore fellow, I was working at a community hospital. It's my last rotation. It was June of 1999. And I was working with a pathologist who was from South America, who had a very thick accent. She's a very good pathologist, a very good GYN pathologist. And that's the first time I ever saw a serous carcinoma in an endometrial polyp. And she made a big deal, kind of the way I'm making a big deal, about being very careful. And she has a very, very thick accent. And she said, you really need to have your testicles out when you make this diagnosis. And I thought, what did she say? And I'm like, I'm pretty sure she said testicles. And to give you some context, a few months before that, I had an autopsy rotation with another attending at UCLA. And he was the autopsy attending. He was kind of a slightly obnoxious, but really funny, really smart pathologist. And I had a kidney in the autopsy that had an undiagnosed, unknown kidney mass that I found when I was doing the autopsy, and it looked like a classic renal cell carcinoma, like golden yellow, orange, hemorrhagic, upper pole, large, looked like it was invading the vein. And I wanted to, on the preliminary anatomic diagnosis, before any sections, I wanted to say renal cell carcinoma. And he told me, he said, Paul, don't stick your balls on the chopping block if you don't have to. So I'm like thinking, maybe all these attendings like talking about, why is everyone talking about my genitalia? So then when she said that, I thought it was odd because she was not like that. She was a little more conservative. And she said it again. And I think I must have made a face like, what is she saying? And she said, what? You know what I mean? You have a good test. You need to have good testicles. You need to have put your testicles out. She said, like the octopus, the testicles. I'm like, you mean tentacles? She's like, no, what is testicles? Is that the same? I said, no, that's what's in a man's scrotum. And she's like, no, this is a testis, no? And I said, it's another word for the same thing. So, English is such a stupid language. You have so many words for the same thing. So anyway, I I thought maybe there was some South America, Colombian saying about putting your testicles out, but she meant you need to really kind of, and this was before we had P53, so you really needed to kind of have a good feel for the case, to really like look at the case carefully, study the case carefully, have your tentacles out like an octopus, and really observe the case and examine the case carefully. Now we're kind of have it easier in a sense where we can do these stains and figure it out. But that also holds us to a higher standard. Anyway, that's my testicle story. So now this is actually an adenosarcoma. So let's talk about other polyps you'd see in the GYN tract. So this is an actual Müllerian adenosarcoma. These are usually postmenopausal women. They're usually low stage. They're kind of the phalloides tumor of the uterus. So they have this classic endometrial stromal cuffing. The sarcoma is more like an endometrial stromal sarcoma, but it's more fibroblastic looking. And again, the glandular epithelium should be benign. These, when they have this architecture, they're very easy. They're usually, like I said, low stage. They recur, but they have a very good prognosis. This is a really classic look where you have a kind of large phalloides, leaf-like architecture, cystic pattern, intraluminal projections in the central or underlying cuffing. This is another one, again, very rigid cystic structures. You don't necessarily see that same tufting, but what you do see really well is that cuffing. And that is kind of classic. That's like, typical adenosarcoma, almost like the stromal sarcoma that you see in the breast, where you just have kind of rounded, rigid cystic glands with surrounding very cellular, malignant looking, but low grade sarcoma. So this was another kind of version of an adenosarcoma. This is getting a little more tufted. But these are the ones that kind of look like that often are missed. I think I have one that's even more subtle. Yeah, so this is one that the cellularity of the stroma is really high. But because it's so high, you don't see the cuffing as well. I think when you stay at low magnification, you see it a little bit better. But then when you look at this closer, this actually looks like a low-grade endometrial stromal sarcoma, which again is usually what these sarcomas are. Now they can have heterologous elements. About 20% of them will have cartilage or fat or skeletal muscle. Again, this one is one that if it was a little less cellular, it'd probably be missed, but because it's so hypercellular, so blue, and when you really look, does have that kind of cuffing, this is another adenosarcoma. Now this is one that a colleague showed me, who I actually worked with both in Texas and in Vegas. We kind of follow each other together. And she's in North Dakota now. Anyway, she's a very good pathologist, and she showed me this case, and she's like, I think it's an adenosarcoma, but it's got something weird about it. It looks like there's too much sarcoma. Is this sarcomatous overgrowth? Now, sarcomatous overgrowth is when, like, I think it's over 25% of the tumor is sarcoma with no glands. And this kind of gets there, but what this more looks like is these cells are more epithelioid and eosinophilic. See how eosinophilic this is? And then I think there's some areas where, again, it looks kind of more trabecular. It looks like there's these almost trabeculae with like palisading. So this is actually sex cord-like differentiation, which you see not uncommonly in adenosarcomas. And one of the things you really see are these lipidized cells. That's something you see in like Sertoli cells. So this was a Müllerian adenosarcoma with sex cord differentiation. And then this is one I had here a few years ago that was a biopsy, and they suspected this was a malignancy in a much older woman. And this, I thought, there's a lot going on here that does not look like adenosarcoma. This is just like solid high-grade tumor. Now, in the endometrium, when you get high-grade tumor, I think carcinosarcomas are probably more common than adenosarcomas. So, and when you have really blue, like malignancy, I don't know if it's undifferentiated carcinoma or undifferentiated sarcoma. It's hard to tell. But this looked like it had these glands with cellular stroma that's kind of cuffing around it. So this I thought looked like a baseline was adenosarcoma. And so then in that case, that should probably be sarcoma. But again, I didn't know, maybe this was a carcinosarcoma because it wasn't that helpful. And then I saw areas that looked like this, which made me think even more so that this was an adenosarcoma, because these kind of look like sex cord-like elements. Again, these kind of trabeculae, I think there are some that actually look like little tubules. These are really good sex cord-like tubules. But then, but what is this? It's very blue. It looks like kind of rounded, very kind of undifferentiated looking. And I thought maybe this is a carcinoma, this is a triple MT, but then, or, carcinosarcoma. But then what are those little glands? Maybe that's like a glandular serous, even though it's bland looking. And then I got to this, and it became much clearer. So what is this? These look very rhabdoid. I was like, oh, that's got to be like alveolar rhabdo, like undifferentiated looking rhabdo, because these all look like rhabdomyoblasts, almost like rhabdomyoma. So then I got stains, and first here's the calretinin, which highlights those sex cord-like elements that just kind of look trabecular. And then here is myogenin, which was strongly positive in all those rhabdomyoblastic looking things, and is also positive within the small round blue cell stuff. Not as much, but you would expect that with kind of more alveolar, undifferentiated looking rhabdo. And then now, if you had all rhabdomyosarcomatous stroma, the differential then becomes, is this a primary rhabdomyosarcoma? Which you can get in the lower GYN, in the GYN tract. But the thing that helps you is if that sarcoma is also ER positive, which is this ER, then it's not a rhabdomyosarcoma, it's an adenosarcoma. And these are often CD10 positive as well. Now, what if you had cartilage with what looks like all rhabdomyosarcoma and a little bit of cartilage? Does that mean that's more likely a adenosarcoma that has different sarcomatous heterologous or elements? No. Embryonal rhabdomyosarcomas in particular can have cartilage in about 20% or so cases specific to the GYN tract. Now, you think of most embryonal rhabdomyosarcomas, which this is one, as being vaginal, young girls, 1 to 5, the sarcoma botryoides, where you have the cambium layer and the surrounding epithelium. The cambium layer is just that hypercellularity around the condensation underneath the epithelium, which is what you have here, where again it's very blue looking. But you get in older women, older girls, adolescents, and women in the cervix and endometrium, you get primary embryonal rhabdomyosarcomas. So it's something you need to keep in mind. And this is one that's pretty easy. There's a ton of strap cells where you can, oh, look at that. You can see the striations just at 40x. So again, this would be ER negative. All right, move on to case 3. So case 3 is a 71-year-old man, history of persistent UTIs, cloudy urine, dysuria, urgency, frequency. Cystoscopic evaluation showed edema with a broad-based tumor in the bladder dome. So they did a biopsy. So this is the biopsy. So low power, my differential is this is either inflammatory or it's CIS, because this kind of edematous, congested background with patchy chronic inflammation is good for either of those. You can't just look at this and say, oh, well, it looks inflamed, so it's probably going to be reactive, because this is the same background you see with urothelial carcinoma in situ. Urothelial carcinoma in situ can be denuded like this, or it can be hyperplastic looking. Now, when it's denuded like this, you really want to go along and look for umbrella cells. When you see umbrella cells, that's much more likely that it's a benign process and that this is probably just denuded basal urothelial cells. But again, you still want to look closer. I think this is pretty bland. It does, it's not completely normal looking. It's a little hyperchromatic, no mitotic figures. Some people fool around with CK20, P53. Those can be helpful. This, to me, I thought that this was all benign looking. I thought it was mostly hyperplastic. I thought even the base kind of here looked very similar to what I was seeing in the denuded area, so I wasn't worried that this was just a focal CIS. This looks pretty bland and reactive. So this is a case of polypoid cystitis. So polypoid cystitis can be a very good cystoscopic mimic. It wasn't for the urologist because he thought it looked inflammatory. This was just to show you what he had said. This was his cystoscopy. He said the dome of the bladder contained a broad-based tumor that was mostly edema of the mucosa, consistent with inflammation and less of a malignancy. He's a very good urologist. He's been here for a long time. So that's just a polypoid cystitis. When you have it on a bladder resection, it's a lot easier because you see how kind of bulbous and polypoid these are. When they get a little more chronic, they get a little more fibrous, a little less edematous. Again, the point is that even though it has a papillary polypoid appearance, the urothelium is not neoplastic appearing, so you wouldn't call it a pun lump or low-grade papillary urothelial carcinoma. That has to be based on the epithelium, not on the stroma. Again, the differential based on the stroma, I think, would be you need to look for, kind of like in an endometrial polyp, you look for serous carcinoma. When you see very edematous stroma in a bladder, you look for CIS, because that's kind of what you see in those cases. And they often present cystoscopically as like little areas of erythema. This is another example.
Sorry, Paul?
Yeah.
For the first case, do we know or care why the guy was getting UTIs?
No.
Okay.
I mean, it doesn't really impact the diagnosis in this case.
Right.
Maybe he has BPH. I don't know. I don't think there's anything that we can see microscopically that would kind of correlate with that. Maybe he has underlying stones. These patients with polypoid cystitis a lot of times have indwelling catheters. He did not. They sometimes have stones. They sometimes have trauma. This is another case where, again, it's hyperplastic looking, very edematous, congested, looks polypoid. You can see this kind of polypoid growth pattern, but again, the epithelium is not neoplastic looking. And then this was a case I just had. This was a polyp. Let's talk about other polypoid lesions in the bladder that maybe are not necessarily malignant or even neoplastic. This was a polypoid lesion in the urethra. In a man. And at first I was like, what the fuck is this? But then I saw this area. I'm like, oh, what does that look like? That looks like prostate. So you get these prostatic type urethral polyps that they're usually in the urethra, often around the verumentanum in men. It's thought that they're either hyperplastic, metaplastic, or maybe just ectopic prostate. Now, the differential is a very important differential, especially with this morphology, is a ductal adenocarcinoma of the prostate, which is often papillary looking and can look very similar to this. But those usually, and they do not often have the same cytologic features as prostatic acinar adenocarcinoma. They often look kind of pseudostratified and not as typical, like prominent nucleoli, etc. But they should not have a basal layer. And so this looked like, to me, it had a basal layer. It looked very bland. It looked very organized. But I did stains just to make sure. Here's NKX 3.1, just to make sure that I am dealing with a prostatic lesion, which is what I thought microscopically on H&E, which I am. And then here's a pin 4, which is, is the cocktail of Amicar or racemase, P63, and a high molecular weight cytokeratin. So if this was a ductal adenocarcinoma, there would be no basal cell staining, and this all has diffuse basal cell staining. So this is just a prostatic type urethral polyp. And this is another papillary lesion, similar to polypoid and papillary cystitis. This is often in the setting of underlying inflammation, catheterization, stones. It's very papillary looking, but it's a single layer of cuboidal to columnar cells that look very bland, but almost look like prostate cancer, where they have kind of a ground glass nucleus chromatin with prominent little nucleoli. But this would be a weird pattern for an astin or adenocarcinoma. This is a papillary nephrogenic adenoma. They often have very thickened basement membranes. I don't feel like it's that prominent of a feature in most of them. This one, I think it's pretty prominent. This looks more like prostatic adenocarcinoma. So if you really were thinking that, if the patient had a history of that, and you saw this and you went down that tube, you could get an Amicar and it would be positive. Racemase is positive in these, P63 is negative. The thing you want to get is a PAX8 because these originate from the renal tubules. So they will be PAX8 positive. They will be NKX 3.1 and PSA negative. So this is just a really very prominent papillary example of a nephrogenic adenoma, just to show you another papillary thing that is not a urothelial carcinoma. And then, okay, just one more kind of mass-forming lesion in the bladder GU tract that is not tumor is this that almost looks like a granular cell tumor, but these are not granular cells. These would be CD68 positive because they're macrophages, and they're macrophages that are unable to kind of digest with their deficiency in phagolysosomal activity bacteria, so they get these little calcific spherules in the cytoplasm that stain positively with von Casa because they're calcific. So what's this, Max?
Malakoplakia, right?
Yeah, good. So here's a little one of it. So this is a case, I think I showed you that one.
Often E. coli, I think.
So yeah, so the gram-negative bacteria, usually often E. coli. This is a case in a
Sorry,
sessile
we
serrated
lost
lesion.
your image.
Oh, you don't have my image?
Yeah, it stopped sharing for whatever reason.
Oh shit. Okay, let me go back. All right, you see it now?
Yeah, we're good.
That was weird. Okay, thanks for saying something. So this is a case of malakoplakia in a colon polyp. And you can see this one has tons of Michaelis Gutmann bodies. And I actually have the von Casa, which I saved, where they all stain black. Isn't that neat? This is a really prominent case of it. So anyway, all right, let's get to the last case where there's apparently controversy, which I found out a minute before this conference. So this last case is a 64-year-old man who had a 1-month history of a painless mass node within his right cheek that appears more prominent from the oral cavity. The mass initially appeared to be growing, but had reportedly stabilized. A CT scan showed a 1.5 by 1.2 centimeter right buccal mucosa mass without associated enhancement or regional lymphadenopathy. Excisional biopsy was performed. All right, so yeah, they're wrong. So the thing I want to point out is that this is a minor salivary gland lesion, because you see all these minor salivary glands. So that's a hint that you're dealing with a minor salivary gland lesion. The thing about this one is that this clearly, to me, looks intraductal. This was associated with the excretory duct, So this was associated, according to the surgeon, with the like where the duct would be from the um, parotid gland. And you can see that this kind of has a papillary appearance. This is very papillary, kind of what you see in an intraductal papilloma in the breast. And so you have this kind of cystic space and these papillary fragments going into it. So now here it looks a little less papillary. It looks more kind of tubular. But the thing about this one that's really interesting, that's kind of characteristic of these tumors, apparently, which I did not know because I had never seen one, I had just read about them, are these focal mucus cells, which is something that's very typical of this lesion from my reading now, where you have it's very glandular, typical, and these focal areas that are mucinous. Almost makes you think of something like a mucoepidermoid carcinoma, but you wouldn't have so much glandular epithelium, although you can get glandular looking mucoeps. But then notice that these are not that, these are elongated tubules, but they're not like pinching off, and they don't have a sclerotic looking hyalinized stroma, and you have these mucus cells that are like punctated throughout. So this is something that I had never seen before, but based on the gross architecture and the fact that it was associated with minor salivary glands, I thought this was a salivary gland lesion. The fact that it was well defined looked like it was probably benign. The fact that it was bland favored that it was benign. It's not infiltrative looking. It looked like it was kind of in a duct or something. It was associated with the duct grossly, according to the surgeon again, who was a very good head and neck surgeon. I had to go reading because I had never seen anything like this. It didn't look like anything I had seen before. And I called this a ductal papilloma. Max was here and he wanted recuts, and I just found out that he showed some attendings, and some people think it's a canalicular adenoma. I was planning on showing you examples of pleomorphic adenoma, which is something you see in the palate, also oral cavity, and polymorphous adenocarcinoma. But I just pulled my examples of canalicular adenomas, and I want to show you how different this fucking tumor looks. This is not a canalicular adenoma. So classic canalicular adenomas have this kind of like kissing trabecular architecture. They are most commonly in the upper lip, like 80% of the time they're in the upper lip. They do not have any of these mucinous glands in them, the mucinous cells in them, and they have this very typical kind of tram track look where they don't have well-defined glands. They're just kind of elongated, kiss, they're kind of run parallel to each other and then they touch, parallel to each other, touch. That's kind of that overall architecture. It's very uniform. That's very typical of canalicular adenoma. I've seen a bunch of them. Here's another one. They all look the same. So they have very, very small trabeculae where they run and they touch, and they're almost always, again, in the upper lip. They're often multiple. This was in the buccal mucosa, which is around the duct, which is classic for a ductal papilloma. Again, ductal papillomas have those mucinous cells, which is described in the WHO as being a feature of ductal papillomas. You do not see that in canalicular adenomas. See this kind of typical going along glandular formation, then they're solid, then glandular formation convene. That's a typical growth pattern that you see that's very uniform, very like ant mini, classic for canalicular adenoma. Going back to my ductal papilloma, this looks nothing like that. This is not like running along, touching. These are well-defined glands. This is, again, very kind of papillary looking. It's within a ductal space, these papillary formations inside a ductal space, lined by a ductal epithelium. You do not have that same tram track appearance. And again, you get these focal mucinous cells, which is typical of ductal papilloma, not of canalicular adenoma. Now, just to go over what I was going to go over, which is something that should be in your differential and any sort of minor salivary gland lesion is most of these are malignant. So, you know, most of the salivary gland tumors in the parotid are benign, like 80% are benign. It's basically flipped when you get to the minor salivary gland. It's most of these are malignant, and this is one of the more common ones. So mucoepidermoid carcinoma is the most common malignancy in the minor salivary glands. One of the more common ones is this, which is a polymorphous adenocarcinoma. The reason I'm showing you this is because this can also be very papillary looking, like a ductal papilloma, but the distinction with this lesion is that the nuclei are very uniform and they're not as bland as what we saw in the ductal papilloma. They are characteristically described as looking like papillary thyroid carcinoma. They're often P63 patchy positive, S100 positive, P40 negative. That's kind of an unusual phenotype to be P63 positive and P40 negative, but that's what these are. They are cytologically monotonous, but architecturally heterogeneous. So they have these kind of trabeculae, often kind of targetoid looking around the periphery. See how this is kind of growing along the periphery. You have what looks like a cribiform area, and then you have areas that look papillary, where it looks like they're projecting into this kind of mucoid looking stroma. Here's another one where this is a differential with adenoid cystic. That's the classic differential with these, is adenoid cystic. But notice, in contrast to adenoid cystic, these nuclei are much more hypochromatic, and they really do look like papillary thyroid carcinoma, which is what people describe them as. And although this area kind of looks like adenoid cystic, when you go around, there are other areas that again look papillary, and then you have kind of these small little glands that kind of peripherally kind of stream out. Again, adenoid cystic looking. This not so much. This is more of like a large papillary area. Again, small little ducts. So that's kind of typical polymorphous adenocarcinoma, which again is common. It used to be called polymorphous low-grade adenocarcinoma. They changed it to polymorphous adenocarcinoma. Before that, it was terminal duct carcinoma. So these names change all the time, but polymorphous adenocarcinoma is the new name in the WHO. They took out low grade. All right. So those are my cases. Any questions? So you go back to your attendings, Max, and tell them they're wrong.
Yes, sir.
All right.
If
you want to come back here, just kidding. Yeah, that's, you know, whatever. It doesn't look anything like it. I'm telling you, it doesn't look anything like it.
Well, and yeah, nothing I found supports canalicular adenoma intraductal like that.
Yeah. It's because it's not.
Yeah.
So anyway, all right. So unless you guys have any questions, I guess I will just see you next time.
Thank you, sir.
Thank you.
All right. Talk to you guys later.